I think that we've been tremendously successful in dealing with coronary artery disease, the atherosclerosis, the plaque buildup in the arteries. Everyone's pretty savvy and aware of their cholesterol levels and where they need to go. I know there's some controversy, and do we still aim for a number or just get someone on a statin or some form of cholesterol treatment? I think the newer agents that are out there for cholesterol therapy, the monoclonal antibodies, the PCSK9 injectables are amazing. I've used them on, my own personal experience is that they seem to be almost miraculous in how well they lower the numbers. There's some emerging data that should be coming out shortly that, not only do we want the numbers to look good, but we want the event rates to go down. And so we'll have a sense of if there's success in actually benefiting our patients by preventing cardiac events. That's certainly an emerging field, but I think the statistics and that nice steady decline that we see across the genders for men and women, that the event rates are diminishing for cardiac death, leaves us with this whole other field. The PCSK9 inhibitors are relatively new. A therapy, it's new to our armamentarium, recently approved, and a growing body of work. We know that they're great for familial hyperlipidemia, and they're covered for familial hyperlipidemia. When we want to expand the breadth of its benefit, it's going to take research. And that kind of research to show outcomes and reduction in cardiovascular mortality, reduction in hospital admissions for coronary disease, it's going to take some time to build that. With the TAVR, the Watchman, the procedural advancements in cardiology, the number of patients to show benefit is so much smaller than a huge intervention like using a monoclonal antibody to lower. So I think in time we'll get there. It's just, the insurance agencies and the federal government needs data. They need to be confident that if they're going to be paying a lot of dollars, they're going to get bang for their buck. And so we just need to let the research mature. It'll be there. I have, not, but it's like getting authorizations for a stress test. You kind of learn the language, the buzzwords, you say a couple of words, and that it changes the way the voice on the other end of the phone, hears the conversation. And I do have 2 patients that are willing to pay out of pocket because they are so desperate. They have been intolerant of every other cholesterol lowering agent, even niacin. So they know that their cholesterol levels are an impediment to their overall cardiovascular health. Mm-hmm. They've had a couple of stents, kind of frequent flyers, so to speak. So they're willing to pay out of pocket for it. I think that the 2 studies that are almost near completion, assuming they have a positive outcome, I think will be very compelling and will probably change that conversation. One area I think that's really has tremendous potential and is already exploding is structural heart disease. So dealing with the valvular abnormalities. So aortic stenosis has already been, I've always wanted that one thing that's dramatically changed the way you viewed a disease in your own career. And I would say the transcatheter aortic valve replacements has been unbelievable. And the fact now that we're going to start bringing it to a lower risk population, not low risk, but like an intermediate risk, because Up until recently, it's been reserved for your highest risk patients who couldn't undergo traditional open heart surgery for their valve replacement. It's just amazing to me that, like, you come in and you have your heart attack and you get a stent within a couple of hours of having your chest pain, and you go home in a day or two, if everything goes smoothly, you'll be able to do that for your stenosed aortic valve. Is amazing. And the ability to return to productive work life, home life, family life, without barely, needing to recover is really like a Star Trek moment.